So Dr. Abrol is the Chief of Neurology, Medical Director of the Stroke Center, and Director of Neurodiagnostics at Gadsden Regional Medical Center. He also serves as clinical faculty at the Alabama College of Osteopathic Medicine and the Edward Bye College of Osteopathic Medicine. He completed his medical degree from India in 2011. Dr. Abrol then did a research internship in the neuroradiology department at MD Anderson Cancer Center in Houston, Texas. He completed his residency in internal medicine and neurology from the University of Louisville in Kentucky, and completed his fellowship training in movement disorders at Mount Sinai School of Medicine in New York. Dr. Abrol resides in Gadsden with his wife and daughter and spends his time off reading, traveling, cooking, and hiking. So we are very excited that we now have a movement disorder specialist in Gadsden. For those of you that say, I don't want to drive to Birmingham, I hate Birmingham, the traffic, the parking garages. We have an option that is local. I've heard nothing but fantastic things about Dr. Abrol, so join me in welcoming him this morning.
Thank you everybody for having me here. I'm going to start for my presentation here. Is it showing? Yeah, my presentation is probably going to be a little bit boring compared to the last one. You did a great job. What my goal is and what I try to do is I want my patients to know about the disease really well. As was mentioned earlier, Parkinson, there's not a lot of diagnostic tests. It's a lot of subjective symptoms. And patients should be the driver of their treatment. Like the patients know their disease best. Everybody's different, everybody progresses differently, and a lot of these Parkinson symptoms are subjective. It's hard to quantify them. There's no test, there's no lab, there's no imaging. So the patients know the disease best, and I want all of my patients to really know about the disease really well, know about the symptoms, what are the different terminologies that we use, what are the basic medications. And a lot of my patients, I tell them they can kind of use medications on their own judgment. So I let them decide how to take their medications. I just guide them, but the patient should be the main driver of this disease management. And that's why I think it's very important to know about Parkinson's disease, know about these technical terms so that you can communicate effectively with your doctor, you can look it up online and understand the whole thing. In many ways, it's a very complex disease. It affects so many different things, but it's also a very simple disease to understand and to take care of. So today, basically, I'm going to do a really quick summary overview of what treatment options we have available for Parkinson's disease. There's going to be a lot of terms about it. And then if we have time, I might touch into another technical thing. It's called atypical Parkinsonism. And then, yes? You can't hear? Oh. Maybe I'm too far away. And then the other thing I might touch into, if we have time, is what we call atypical Parkinsonism. But I also want to, do a little bit of Q&A if possible. If anybody has any questions, because I won't be here, unfortunately, for a panel discussion. So if anybody has any questions for me, if anybody, just raise your hand in the middle of talking, and we can address those. So, all right. So Parkinson's disease, unfortunately, it's a very common disease, and it's getting more and more prevalent as the population is aging more. We're living longer. Parkinson's disease, like I said, it's a complex disease. There's a lot of motor symptoms, which basically means physical symptoms, but there's a lot of non-motor symptoms as well that are, you can call them non-physical symptoms. In the past, we mostly focused on the motor symptoms, but now we are figuring out that non-motor symptoms are as important, if not more, and have been ignored for a while in the past. And then, like I said earlier, every patient is different. That's why the treatment should be individualized. Every patient, should have a good care team that works one-on-one with them and help them treat their symptoms. And then the last point I wanted to make was here is there are situations where, because we don't have a definitive test for it, I still see patients who've been incorrectly diagnosed. Either they're not diagnosed with Parkinson's, obviously, but also they're diagnosed with Parkinson, they don't actually have Parkinson's disease. So it's very important to see like a neurologist, especially if available, somebody who's trained in movement disorders, which is, you know, doctors who train in this Parkinson's disease and similar diseases. So, like I said, a lot of symptoms are subjective, and that's why the patient should be the driver of the treatment, and they should, you know, be able to talk to their doctors in good detail. So, like I mentioned before, there's a lot of motor. These are the main motor symptoms or physical symptoms. So you'll hear these terms, if you read online, you'll read these terms. The first one is called the bradykinesia. That means really just slowness of movement. All your movements have slowed down. Things that you do on your day-to-day basis is just slowed down. And that's one of the things that we test for when you come here. And then you have a tremor. There's different types of tremors, but the Parkinson tremor is usually worse when you're resting, when you're not using your hand. And when you're trying to do something, it gets a little better. Not everybody, but most of the times when you move your hand at first, it gets better. But there are other diseases where it's the opposite. And then you have rigidity, which is stiffness of muscle movements. Your muscles get very stiff and tight. And you know, I get a lot of patients before they got diagnosed with Parkinson's disease. Sometimes they'll have like this frozen shoulder. They've been to orthopedic doctors for a year or two. They've had surgeries because they thought they had frozen shoulder. But I mean, they might have that too, but in reality, they really had Parkinson's disease that caused the frozen shoulder. And if they were diagnosed sooner, they might not have needed those surgeries. And then, you know, a lot of balance issues, postural issues, swallowing problems, and then fatigue, lack of energy, and things like that. So these are kind of the main terms, the bradykinesia, tremor, and rigidity that are kind of, you know, I want you to understand, because people will use them all the time in medical terminology. These are some more terminologies that I want you to be familiar with. The first one, that's called the dyskinesia. A lot of people get confused about it. Basically, dyskinesia is a different type of abnormal movement than your tremor. So a lot of people will have like a tremor, but if you've seen somebody with advanced Parkinson's disease, they have this kind of hyperactive movement of the whole body. That's called dyskinesia. And this is very important to recognize, you know, by the family, by the patient themselves, because dyskinesia is not associated with, you know, it's not a sign that you need more medication. It actually might be the opposite. It might mean that you actually need less medication, because dyskinesia, it can look like a tremor of Parkinson's disease, but like I said, it sometimes is because of too much medication in your system. So that's an important kind of term and symptom to recognize. I want you to kind of talk to your doctor if you're not clear about it. Like, hey, how do I, you know, separate my tremor from dyskinesia? Because that's very important. And then sometimes we'll use the term wearing off. That just means that the medication is not working until the next dose of medication. So it wears off before it's time for you to take the next medicine. And then we use the terms on time and off time. On time means how much time during the day you are feeling good, physically and otherwise. And off time means how many times you're not feeling good throughout the day. And then, so if you look at the graph, it basically shows as the disease progresses. In the beginning, the white portion in the middle, the white triangle, that's the good time, that's the on time, when the medicine is working really good, and the one in the bottom, the dark blue one, is the off time, when you're not doing so good. And the top one, the light blue, that's the dyskinesia. So as you can see, as the disease progresses, the dark blue in the bottom, which is the off time, which is the bad time of the day, gets more and more, and the white triangle, which is the good time or the on time, that gets less and less. Even though the dose of the medicine in your blood, the level of the medicine in your blood is the same. So that's, unfortunately, as you can see in the beginning, most people do really well, but after a certain period, it starts getting more tricky. And then, as you can see, dyskinesia starts getting more and more common and more prevalent. So these are some more terminologies that I want all my patients to be familiar with. Most of my patients who come to me, we kind of talk about them, and I make sure they understand the difference between, if they're having them, the difference between the Parkinson tremor and the dyskinesia and these things. All right, let's go to some. Does anybody have any questions for now, for these motor symptoms or any terms that we talked about? Okay. Yeah, let's briefly touch on these non-motor symptoms. I want you to make sure whenever you see your doctor that we touch upon these symptoms every time you see your doctor. Just briefly make sure, because there are, the Parkinson medicine don't address most of these symptoms. So for most of these symptoms, there are other medications, there are other therapies, other things that can be done for these other symptoms. So a lot of times people will just talk about their physical and motor symptoms, but they would ignore these non-motor symptoms. So I want you to talk to your doctor about these non-motor symptoms every time you see them. So there are things like any kind of mood issues, depression or anxiety, or sometimes a lot of people will get these psychosis symptoms like hallucinations, seeing things that are not there, things like that. You have cognitive impairment, you have lightheadedness and dizziness. Blood pressure issues are very common. Urinary and sexual problems can be seen. Constipation is very common. Sleep disorders, there's something called the RBD or rent behavior disorder. A lot of Parkinson patients tell me that, and we know now that it's true, that they'll have sleep issues for a long time before they even got diagnosed with Parkinson's disease. Basically people have a lot of vivid, lifelike dreams. Sometimes they'll, move a lot in their sleep and things like that. Fragmented sleep, insomnia. Loss of sense is another big one. A lot of people, they'll tell me, oh, I've always had a bad sense of smell. They'll attribute it to something else. Oh, I used to get bad sinus infection, or it happened when I was pregnant, and since then I could never smell. And that's, we know now that sometimes it can happen decades before the actual diagnosis of Parkinson's disease. And then drooling is another common one. A lot of people will have drooling of saliva with Parkinson's. So these are kind of your common motor symptoms that I want you to kind of review yourself, with your caregivers, and definitely with your doctor every time you see them. Okay, so what are the treatment options that we have now for motor symptoms? We won't go into the non-motor symptoms today, but motor symptoms, we'll talk about it a little bit. Might be a lot of dense stuff here, but really, in summary, what happens in Parkinson's disease, you have this chemical in your brain, this neurotransmitter called dopamine. Dopamine goes down, and our job is to replace the dopamine. So there are different ways to replace the dopamine. The classic medicine that majority of patients take is the Sinemet or carbidopa levodopa, which is, unfortunately, that's still the best medicine that we have. This is one of the first medicine that was discovered for Parkinson's disease, but I think it's still the best medicine that we have for Parkinson's disease. It basically, what I like to say, gives you the best bang for your buck. It gives you the most benefit with the least side effects, and usually works really well. Like we saw in the graph before, it works really well in the first few years. It keeps working, until later, but later on people start having a little more side effects and it gets a little more tricky. You just have to do a little more fine tuning. But I think this medicine, the Sinemet, is still the one that works the best for most patients. And so if you're on Sinemet, you don't have to worry about all these other medicine. If you see an ad or if you read about like a new medicine, should I be taking that? I mean, obviously discuss with your doctor, but I think Sinemet is still the best medicine. Now, the other medicines, they have a role for sure in specific situation, like some of these medicines, the Rytari and Stalevo, they're good longer acting medications. If somebody is having to take their Parkinson medicine every 3-4 hours or something like that, you can definitely try a different medication that can last longer. Or if your medicine is taking too long to kick in, like if it's taking you, after you take it, as some of you might have noticed in the beginning, the medicine works pretty early, right away. But after a while, if you've had Parkinson's for 5-10 years, it might take 15 minutes or 30 minutes or 45 minutes to even kick in. And sometimes you might get off before it's time for you to take your next medicine. So there are solutions for those situations. There are these medicines called the dopa agonists. Like I mentioned here, they can help boost the effect of your primary medication. These are what we call the add-on. These are the add-on medications. That means they're not typically a first line. First line is always one of those first ones like Sinemet. But then on top of that, you can have these add-on medications. You have these amantadine, gocovri, Osmolex. You have some other medicine, Artemisinin, Compan, Azilect, and all these medicines that I've mentioned here. Like I said, they're not primary medicines most of the times. Maybe in early disease you can use them as primary medicine, some of them, but most of the times these are going to be add-on medications. So let's see. Yeah, I think that's all I wanted to say about these medicines. Okay. All right. Now, so that's really the main medication options that we have. We have the primary medicines, which is Sinemet and a couple of other medicines, and then you have these add-on medicines. So almost everyone should be on the primary medicine, and then if needed, you should have maybe a secondary add-on medication. But like I said, there is still no better medicine than Sinemet for most people. So exercise, a lot of you've talked about it earlier, and I'm sure people will talk about it more. It's extremely important. If you have Parkinson's disease and if you're not exercising, you're missing out. You're missing out on a major therapeutic that we have, right? Consistently, we've seen studies after studies that show people who exercise with Parkinson's, they do great long term. Their progression is slower. They have less risk of morbidity, falls, injuries, and stuff like that. So exercising, like I said, it's as important, if not more, than your medications. All right, rain or shine, you gotta do something. You gotta move. I know it can be hard, but it's something that you have to push yourself. The caregivers have to push your patients to exercise. And any kind of exercise, any kind of exercise you can do. The best one is something that involves a little bit of a cardio, low cardio, maybe a little bit of a good hand-eye coordination, some balance exercises. The LSVT stuff is really good. Dancing, biking, stationary bike, or biking otherwise, yoga, tai chi, PD boxing. These are some really good exercises that work on your balance and give you a little bit of cardio. You can do a little bit of strength training. I would put strength training below all of these exercises, because most of the times in Parkinson's, strength is not that much affected. But like I said, any type of exercise is great. So definitely, focus on getting 30 minutes out of your day to do that. And then diet and nutrition. So people ask me this question a lot of times, like any specific diets and nutrition for Parkinson's. Really, there's no Parkinson's specific diet as of now. There's nothing that's specifically better for Parkinson's disease. In general, there are some thoughts about a high iron or high protein diet that can interfere with your medication absorption. So especially later on in the disease, when you need like that every small percentage of that medication. you want to avoid eating like a super high protein, high iron diet right around your medication time. So like a steak or heavy meat diet, maybe an hour or two around your medication, you can avoid. But other than that, really, I encourage most of my patients, my personal recommendation is to eat a well-balanced, healthy diet, a little bit of everything. Eat some proteins, eat some nuts, eat some seafood, eat some vegetables, eat a little bit of a healthy everything, and definitely keep an eye on your weight, because sometimes people with Parkinson will start losing a lot of weight because of the tremor, because of not eating well. So losing weight, too much weight is not, obviously too much weight is not healthy either, but losing too much weight is not healthy either. So keep a close eye on your, check your weight on a regular basis as well. Make sure you're not losing or gaining weight too much. And then, if you look it up online, you might see a lot of, these days it's so hard to navigate the nutrition and diet world. You'll have people on one spectrum saying do vegan or do this, and then you'll have the other spectrum doing keto or this type of meat heavy, protein heavy diet. So it's, I think for Parkinson's specifically, I don't think either one of them is better, as long as you're getting all your nutrients and as long as you're avoiding bad stuff like too much fast food, too much of anything, too much salt, too much sugar, too much saturated fats, which are good, which are not good in general. You should be okay from Parkinson's standpoint. This is one example of a healthy diet pattern, the Mediterranean type diet. It's not, it's not the only recommended diet, but it's just the one example of a healthy type diet that you can follow. That it has a lot of, as you can see, it has a lot of vegetables and nuts and beans and fruits, olive oil, which should be like 70%, 80% of your diet, and then fish and seafood is kind of another 10 to 20%, and the remaining 10% should be dairy, eggs, poultry, and your meats and sweetmeats. But like I said, this is not the only healthy diet, but this is a good example if you're looking for a set diet, and you can follow that easily. Caffeine has shown some positive effect. I don't think it's it's a big effect. There were some studies that show that people who drank a lot of caffeine did better long term, but I don't think the effect is as important. So if you like coffee, go for it. It's not something you have to drink. Definitely make sure it's not affecting your sleep. So if you do consume coffee or caffeine, make sure it's more earlier in the day rather than later in the day. Okay. Anybody have any questions so far? Anything about diet, exercise, any of these medications that we talked about? All right. So let's talk about briefly about some other treatment options that we have available. All right. So we have this deep brain stimulation. All right. You might have read about it. You might have heard about it. You might have had other talks about it. But basically, in summary, we take an electrode, we put it in some deep areas of your brain where we think Parkinson's disease starts from, and we don't know exactly completely how it works and why it works, but there are some theories about it and why it works, but it definitely works. It helps a lot of motor symptoms of Parkinson's disease. So if somebody is having a lot of physical symptoms, it will help you, but it won't help a lot of non-motor symptoms. And in some cases, it can worsen some of your non-motor symptoms, like cognition especially. So if somebody's having a lot of memory issues or thinking or issues like that with Parkinson, this might not be a good option for those patients. But if you're having a lot of physical symptoms, but your memory and thinking is completely fine, this will be a good option to consider. Especially if you're having to take too much of your Parkinson medicine. If it works for you, but you're having to take too much, or you're having a lot of those medication-related side effects that you can't tolerate too much of your medicine, that would be the perfect patient for deep brain stimulation. That you don't have any cognitive issues, and you do really well with your medication. The medicines work for you, but either you're having to take too much, which is causing you some medication-related side effects, or in general you just don't want to take too many medication, and that would be a good patient for a deep brain stimulation. And then you have some other options. Deep brain stimulation, it's still a surgery. They still have to open your brain a little bit. They have to make a hole and they have to go in there. And you have a wire, you have a battery here. So there's definitely, it's a surgery, it's a procedure that has to be taken care of. Sometimes for patients who are not good candidates for surgery, who are high risk for surgeries, or people who don't want to do surgeries, this is a relatively, in some ways, newer option, because people used to do something similar in the past, but now this is, the FUT. It's basically, in summary, without opening your brain, they'll use some ultrasound waves from the outside. They'll put you in a scanner like that, and they'll use these waves that will basically make a tiny hole in that part of your brain, close to where we do the deep brain stimulation. It's like giving you a small stroke. All right, they'll give you a tiny stroke in that part of the brain, but it's not a surgery. So they're not opening you up. They're just making a tiny stroke there, and that has shown to help a lot of patients with their physical and motor symptoms. The good thing about this is it's not surgery. It can be done for any patient, really, even if you're not a good candidate for surgery. The bad thing is, as you can imagine, they're giving you a small stroke, and it's a irreversible procedure. So once you've had it, if things go bad, if you have any problem with it, if you have a side effect from it, there's no going back, really. They can't undo it. With deep brain stimulation, it can be undone. They can take it out, or they can change the amplitude of those stimulus that it's giving, but this one is not reversible. So sometimes people will have permanent weakness on one side a little bit, maybe some slurred speech and things like that after this procedure. So that's like I said, it would be good for a patient who has a lot of tremor, I would say. Somebody who has really bad tremor, which is not working as well with the medication, and they're not a good candidate for DBS. Somebody who might be older, somebody who might have a lot of cognitive issues. I think this would be a good treatment option for them. And then we have another thing, it's called duopa. It's basically making a hole in your stomach and putting a tube and having a continuous infusion of your medication through that tube. Because normally our body secretes dopamine continuously. So whenever you're taking the medicine, you're not taking it, continuously. You're getting it, every 3 hours or 4 hours or 6 hours, however you take it. So that's why you get this curve. You get a high dose and a low dose and a lot of side effects. But with this, you can have a constant, just like some people have that insulin pump. You just get a continuous, infusion of dopamine. It has its problem, obviously. It's not as simple as an insulin pump. It's a little more invasive. It's a little more, invasive surgery. They have to, as you can see, they have to make a hole, and they have to put a tube. So there's a lot of caretaking of this tube and surgery and stuff like that. There's a risk for infection and things like that, and you have to change the cartridges of the device that holds the medicine in there. So that can be a lot of work too sometimes. So that's the duopa pump. So these are kind of really still this main treatment option that we have. We have the medications, we have deep brain stimulation, we have duopa, we have the FUT, and then exercise. These are kind of the main 4 or 5 treatment options that we have for motor symptoms of Parkinson's disease. There are various studies going on. There's a lot of stuff about gene therapy, stem cell therapy. There's some antibodies in the work, nootropics, and then the DBS technology that keeps getting better and better as well. So these are some kind of things people are working with. And as somebody mentioned, there's always trials going on at academic centers, UAB and stuff like that. So if you're ever interested, find out. You can find information about a lot of trials. It's a public information. You can find it online. on government websites, NIH websites, and different centers have different types of trials that you might be eligible in. And I'll be honest, I'm not always up to. Sometimes patients will tell me like, hey, I was looking about this new study they were doing at UAB or Emory or wherever that I might be a good candidate for, and I'm like, oh, I didn't know that, because they're like, always starting new studies, but I will look it up. I will, and then I can let them know like, oh yeah, I think you might be a good candidate. You should talk to them. But you can talk to them directly as well, and they will, help you with that for sure. But that's why it's important to stay up to date, keep looking, be a part of all these communities, so that somebody might be a part of a study that you're not aware of. So it's good to have a support group where you can talk to other people. So so these are kind of the summary of living with Parkinson's disease, things that we discussed. Make sure you are really familiar with the disease. Make sure you read about it. Make sure you stay up to date. Make sure you have a good lifestyle. You're eating good. Make sure you're doing exercise on a regular basis. Very important. Make sure you have a good healthcare team. Find a trusted team of doctors and nurses and support group, and because like I said, the disease is very individualized, like everybody's different. So it's good to have a good relation with a doctor that knows ins and outs about your disease specifically, and they can help you fine-tune your treatment better if you have a reliable team. And then participating in trials if you like, and then finding local resources, and then having good, a good social group, having some hobbies and a higher purpose in life. Those things have shown consistently to, be associated with better long-term outcomes. Okay, so that was kind of the main summary with Parkinson's disease. I just wanted to touch a couple of things about this. I want you to be familiar with this term as well. It's called atypical Parkinson's. Okay, this is basically patients who look like Parkinson's disease, but they actually don't have Parkinson's disease. They have something else. And this guy, Robin Williams, like he was diagnosed with Parkinson's disease most of his life. Everybody knew he had Parkinson's disease, but when he died, they did an autopsy and they found he actually did not have Parkinson's disease. So even celebrities who have the best resources available, they can be misdiagnosed because we don't have a definitive test for it, and a lot of these conditions have overlapping symptoms with Parkinson's disease. So that's extremely important that we make sure that you have the right diagnosis. And obviously this is the job of your doctor. This is the job of your physician, and that's why it's important to have somebody who's who knows what they're doing. A neurologist is definitely important, and if possible, if you have availability of a movement disorder neurologist, you should see them. Especially if you're not showing a good response to treatment options, that would be a sign that, okay, maybe this is one of those atypical Parkinson's disease. So that's your main signal that you might not have Parkinson's disease if you're not. Because most people, especially in the beginning, whenever we start Parkinson's medication, they feel a lot better. Especially in the first 3 to 5 years, most people, once I start them on the right dose of the right medicine, they'll come back 2 weeks, a month later, and they'll be like, I feel great. I feel a lot better. So if you're not having a good response to levodopa, amongst other things, one of the possibilities might be that you might not have Parkinson's disease in fact. And there's a lot of red flags, and like I said, this is the job of your doctor to know and figure it out. But the main thing for you is no response to the medication would be a good red flag for it. But there are some other features like if you're getting worse really fast in the first 3 to 5 years, somebody's getting wheelchair. The first 3 to 5 years, which should not happen with a typical Parkinson, or you're having a lot of cognitive issues in the first couple of years, or you're having a lot of what we call autonomic symptoms, that your blood pressure is fluctuating, you're falling a lot, those kind of things, especially early on in the disease, first 2 to 3 years. Most people with Parkinson in the first 3 to 5 years do really well. They look normal, they feel normal, or close to normal in the first 3 to 5 years. So if you're not there, either you're not on the right medicines or your diagnosis is incorrect. So in that case, I think it would be best to see somebody who's trained in movement disorders if you're in that situation. So, these are some of those conditions that, again, you don't have to know about any of these, but these are few conditions. The point being, there's a lot of conditions that can look a lot like Parkinson. And sometimes in later stages, nobody can tell them apart until you do like a biopsy. But in early stages, a properly trained person, experienced person should be able to tell them apart in the beginning. And then, all right, so I think that's all I have. That's my little helper there. That's my little daughter. All right. Anybody have any questions for today? I know there was a lot of technical. Yes.
The Duopa or the pump to the intestine, is that an option for people who, for whatever reason, are not very good about taking their medicine, staying on a schedule, or are there too many risks and side effects associated with that?
Yeah, I think yes, but the only thing is, it also requires somebody to care for it, because you have to replace the cartridges. It has these cartridges that somebody has to replace like once a day, depending on how much you use, how much they need. You have to replace those cartridges. And there is like an open wound here where the tube goes in. So if somebody has, I had a patient who pulled it off. They got a little confused and they pulled it off in the middle of the night, and that was a disaster. So patient should be able to care for it, or at least a caregiver should be there to kind of look at it, make sure the wound is not infected or something, there's no stuff going on, and make sure they're able to change the cartridges on a regular basis. But otherwise, it would be great for somebody who's having to take the medicine every 2-3 hours, because we have patients who have to take it every 2 hours, 3 hours, and that would be a great option in those situations. Yes?
What would you say is the most common thing to be mistaken for Parkinson's?
I think in the beginning, essential tremor is actually, I get a lot of patients from primary care doctors, essential tremor versus Parkinson's disease. That one is pretty straightforward and easy. Most of the time, sometimes it's not clear, but sometimes I'll ask patients like, hey, let's wait on it, let's give it another 6 months and we can reassess. But Lewy body dementia, or dementia with Lewy body, is probably the second most common reason, thing that people get confused with. The main thing about that is if you have a lot of hallucinations, cognitive issues early on in the disease, in the first 3 years of the disease, then think about Lewy body disease. Because Parkinson patients should not have that early on. Later on, yeah, but not in the first 2-3 years. Yes?
Could you tell us a little bit about, the last stage? My dad, I believe, stage 5. We just had to place him in a nursing home.
Yeah.
What do we expect? I mean, he's one of the reasons we had to do the nursing home was he had the retropulsion, where he just and we just couldn't get him in and out of the bed well.
Yeah. Is he on a wheelchair and stuff now?
Well, before he went in, we were doing a walker and wheelchair, but now that he's in a nursing home, he can't hardly even stand up. They're afraid he's going to fall. Because, I was real forceful with him. I'm like, come on, Dad,
Yeah.
But they're afraid he's going to fall, so they're just using the lift and things, and he's just going down the field.
Yeah, I think, unfortunately, this is what we call a progressive neurodegenerative disease. It does keep getting worse and worse. Everybody's different. I have patients who've had it for 20 years, they're still doing okay, but sometimes in 5 to 10 years, people do get to, the last stages where nothing works, the medicine doesn't work. The first thing in those situations is safety, making sure he's safe, he has the right resources, whatever he needs, because Parkinson patients, they don't have issues with living a certain number of years. Most people have problems when they fall or they get an infection, and that's what causes problems. Parkinson patients fall a lot later on. So that's safety is number one at this stage. There's that's the best thing you can do is make sure they're not falling. So whatever help they need, wheelchair or sport, and then before they get to that point, therapy is very important. Making sure they're getting good therapy and PT, OT, and they can help you with a lot of those things before he gets to that point. And
He's 83 and he was diagnosed at 69.
oh yeah, so he's had it for, well, still a little fast, but some people, it can happen. They can get there. Also, make sure there's nothing else that's causing that problem, because sometimes with Parkinson medicine, people can have a lot of blood pressure issues.
He
And
has postprandial hypotension.
yeah,
So he's
and
on
that
he's on
exactly.
Dopa.
Yeah, and that can cause people to fall a lot, and sometimes you might have to lower their Parkinson medicine later on in this disease, because the benefit is not worth the side effect. If he's mostly in a bed, in a wheelchair, I mean, the Parkinson medicine, giving him too much is not gonna help him, because those medicines help people to walk better. So it's not gonna help him much, but it's probably giving him some side effects. Too much of that medicine causes people to have cognitive issues, hallucinations, and lightheadedness and hypotension, where they fall down every time they stand up. So and make sure there's no spinal cord issue. Sometimes arthritis in the spine can do that too. So I think those are kind of the main things. Safety is number one. Therapy, if he can still do, and then making sure there's nothing else that's causing that problem. But I don't think there's any medicines to help in that stage. Right. Anyone else? All right. Okay.
So from a quality of life perspective, what's the ideal stage to consider a procedure like deep brain stimulation?
So things have changed. There are, in the beginning it used to be like, until you're responding really well to the medication, you should just stay on the medication. But once you get to a point where you're not doing so well with the medication, that would be a good time to think about DBS. And that's what people started, that's what the thought was in the beginning. There was a period where people were saying early deep brain stimulation, maybe 4 years into the disease, might have some beneficial effect. I personally don't see that evidence yet, don't see that data yet, so I usually don't recommend that until I feel like the medicine is not, medicine is working, but either we're having to use too much medication, or they're having a lot of that dyskinesia movement, the side effects from the medication. So, or they're getting a lot of hallucinations, or they're getting a lot of lightheadedness. That's when I would encourage them to get DBS, and if they don't have cognitive issues, major cognitive issues. So basically everybody is different. It's not everybody. Someone might be a candidate in 4 or 5 years, and somebody might not need it ever. So I think that's a good one-to-one discussion to be had with your doctor. Yes.
I've been reading a lot about B1.
About what?
B1.
Yes. Yeah. So yeah, I thought about putting all that stuff here. There is a lot of, if you look it up online, there's a lot of stuff about B1 and CoQ10 and this and that. There's a lot of supplements there. I don't think they're harmful, so you can take them in reasonable doses. I personally don't see, if you have a good balanced diet, I personally don't see a major benefit from any of those supplements. I think I still focus more on nutrition and diet. And I do recommend most of my patients to take just an over-the-counter multivitamin that has everything, that has B1 and all those vitamins that we need. Anything you take too much, you just pee it out. It's not going to get absorbed in your body. So a regular multivitamin over-the-counter is all you need. Most other supplements, they might have a small beneficial effect. I haven't seen a good evidence for a great effect to the point that I'm recommending that any of those to my patients. But yes, just an over-the-counter vitamin should be taken by most people. Yes.
President George H.W. Bush died in his early 90s. Over the media, they said from complications of Parkinson's disease. And I've noticed over time, a number of older people have been, that's the reason they gave from dying, but they're in their 90s.
Right.
What is a complication from Parkinson's disease, that causes people to die.
Yeah, I mean, like I said, Parkinson's disease, people don't, die because of Parkinson's disease directly. They die because of complications of Parkinson's disease. So if somebody does not have any complications from Parkinson's disease, they will live as long as general population, and he lived to 90, which is way more than general population. So the common reasons why people with Parkinson, die or have, bad hospitalization is pneumonias. So because your swallowing is affected, you're not swallowing as good. So even your own saliva or your food or water, that it can go into the lungs. And pneumonia is a big one. And then falls is another big one. People will fall a lot, they'll get concussions and injuries and stuff. Those are the two main reasons why people with Parkinson's disease have bad outcomes. Infections like pneumonia that eventually spreads to the whole body, or falling and complications from injuries related to that. And once, it's like a vicious cycle. If you were to, God forbid, have a small fall, you get a small fracture or injury or something, you're hospitalized. Once you're in the hospital, it's like you can get more infections there, you can get blood clots, you can get all kinds of stuff when you get side effects from the medication that you're getting. If you're older, even antibiotics can cause you to have side effects. So it just puts this vicious cycle once you have a small issue. So, but yeah, those are the two main complications from Parkinson's disease. Yes.
And what can be done to assist improving swallowing?
Yeah. So again. First thing is recognizing that you're having trouble. So your caregivers and yourself, like if you're having trouble with eating, when you cough when you're eating, you choke, you gotta get a swallow study first. You gotta talk to your doctor, you gotta get a swallow study and see how bad it is, and first make sure there's nothing else, but then get a swallow study and see what's happening. And usually the first step would be a modified diet. You might have to modify your diet a little bit at that stage when you're having trouble. So a speech therapist would be, great to help you with that, help you what type of diet is best for you. And then sometimes there are things they can do. The GI doctors can dilate your esophagus, and they can do some therapy as well, that swallow exercises that can help you as well. Some of my patients, they'll get a lot of drooling of saliva, which is a sign that your swallowing is impaired, that you're not swallowing as good. And sometimes we can do some medications or even injections to dry the mouth if needed. So you can do those too, but main thing is just being aware that that's the problem, and then getting a swallow evaluation, a study, and then modifying your diet accordingly. I think that's the best thing you can do. And Parkinson's medicines do help with swallowing issues, so sometimes increasing your Parkinson's medicine can improve your swallowing, because swallowing is a muscle issue. So if your muscles are weak, you're not swallowing as good. So sometimes increasing your Parkinson's medicine, even if you don't have other issues, but your swallowing is getting worse, that could be a discussion to be had, that maybe we can try increasing your medicine and they might help. Yes.
Are there any new treatment options for Parkinson's with dementia?
There are some medications for people who are having a lot of what we call behavioral issues. So people who are having a lot of hallucinations and things like that. Not dementia per se, but like behavioral issues like hallucinations or agitation and things like that. A lot of people get that, especially later in the evening. So there are a couple of medications that can be used for those situations. There's the Nuplazid is one of those medications that's been there for a while, and then there's another new medicine that recently got approved for people with Alzheimer's who have behavioral issues, and I think that can also be used for Parkinson's disease patients.
I mean, he's on Nuplazid and Rivastigmine.
Yeah.
Okay.
Yeah, I think Nuplazid is a good option, but there are some other medicines. The older medicines sometimes work best. So if Nuplazid is not working, the reason we used Nuplazid was it was not supposed to make your Parkinson's physical symptoms worse, because some of the other medicines that we had used in the past, they can make your physical symptoms worse, even though they can make your behavioral better, but they'll make your physical symptoms, Parkinson's, worse. So Nuplazid was supposed to kind of do that and prevent that. But if somebody's Nuplazid is not working, then it's time to go back to the older medicines. there's risperidone, there's Seroquel, things like that. And Seroquel, you can go really high on the dose if needed, and sometimes you have to use both. And there's a few other options for those some of the older medicines. But Nuplazid is not always strong enough, I would say. And there's that, the Rexulti is the new one that got approved for Alzheimer's disease agitation. But I think that can be used in Parkinson's disease as well. Yes?
The procedure, the brain stimulation, where you recommend, where they induce a stroke, would that be recommended for someone who has already had a stroke? Would that be a treatment that you would?
That's a good question. It's tricky, it depends. It depends where the stroke is in your brain and how bad the stroke was and how much deficit somebody has from a stroke. If you've had a small stroke not close to the area where they go and you don't have a lot of what we call residual deficits from the stroke, I don't see, if you're otherwise a good candidate for that procedure, I don't see a reason why you won't be. But if that stroke was close to the area where we normally go, or you already have deficits, already have weakness on one side or the other, then I don't think it'd be a good option. I would go towards DBS in those situations, the deep brain stimulation. Okay. Anything else?